So Dr. Kavita Rao is a cornea specialist practicing in Mumbai in private practice, and she has a great academic interest in many subjects. She's going to talk about Tenons patch graft, which will help us and come to the rescue.
Thank you so much, Dr. Somshila, for having me as part of this IC. So I think the previous speakers have been talking about managing corneal perforation. So corneal perforations have a variety of presentations, and the management, of course, will depend on what the cause is, especially whether the cause is infective, whether it's immune. We have a lot of options: the glue BCL, conjunctival flap, amniotic membranes, and corneal patch grafts or a keratoplasty. Now, where does Tenon's patch graft fit into all of this? The goal, of course, is to have a watertight chamber, and these are the indications for a Tenon's patch graft. So wherever you have any neurotrophic ulcers, herpetic ulcers, or you have immune-mediated diseases like OCP, Stevens-Johnson's, all of these are the indications where Tenon's graft is going to play a role. If there's an active infective component, usually there is no role of Tenon's graft. I'm just saying usually because I'm going to show a case where we have used it in infections also. But typically I would say the most indications would be for immune cases. Now, how do you decide your case? Obviously, if the the perforation is smaller, it's around 2 millimeters or lesser, a glue BCL works the best. And if it's more than 6 millimeters, then there's no role for any of these, either the amniotic membrane or the Tenons. So now the dilemma is when it's going to be between 2 to 5. That's where the dilemma is: do we use an amniotic membrane? Do you use glue do you use a multi-layered AMG or a Tenon's graft? So obviously a Tenon's graft will be better because you don't need to contact the eye bank. It's an autologous harvesting. And also, if you're gluing the patient, then even if it's a smaller perforation, then you can't put a BCL in cases of OCP. Then again, Tenons is going to be superior. So this is a paper by Dr. Sayan Basu, where he has published. I think it's a very good indicator as to how you decide about Tenons. So most of the times, if it's a smaller perforation, non-infective, you can see that the glue BCL and Tenons both seems to work well. Whereas if it's a complete sloughing, active microbial infection, then there's no role for your Tenons. Now, how does it act? It basically acts by, there is a mechanical plugging which is happening because it's it's like a volume replacement. You've lost cornea there, and mechanically it's plugging the area of perforation, and also it provides a scaffold over which the surrounding epithelium now migrates. The difference here is that the fibroblasts here, which are coming from your Tenons, are different from the corneal fibroblasts. The corneal fibroblasts are more sensitive to inflammation, whereas the Tenons fibroblasts have a dampened response to inflammation. I think this is a very important point because that's why I guess the Tenons grafts is doing well. This is a histopathology again published by Sayan, where you can see that it's pretty well. You can see that the collagen within the cornea is formed, and then the Tenons epithelium is growing over it. This is a very interesting paper published by Dr. Sushmita, which I feel is a little different from what has been published by Dr. Basu. Here, after she's had done a Tenons graft, she's done an optical keratoplasty, and here, as you can see, the Tenons graft is actually integrated in between, and the corneal stroma has also grown over it. So, which postulates that the Tenons also contains autologous fibroblasts, which helps into integrating into the corneal stroma, which I feel is probably can have a paradigm shift in the way we think. Coming to the technique, it's pretty simple. Just running both the videos side by side, you just harvest the Tenons, and you can then freshen the edges of your desmetocele, or your if you have like an impending perforation. There are various techniques which have been described for suturing it. I don't know if the panelists they use glue, but I think using a mattress suture has been well described by the LBP faculty who first started doing it, and I think that really works well. Once you freshen the edges, you just put the graft, the Tenons graft, and you take the good mattress sutures, and at the end of it you can place a BCL just for comfort if the patient feel it's needed. The other thing is you can always combine it with using the amniotic membrane also. It's not necessary that you'd have to, maybe I'll just forward the video a bit. Oh, sorry. I don't think it allows me to forward, yeah. Yeah, so this is, you can see that the mattress suture out here has been taken, and pretty simple surgically for a cornea surgeon. Now this is a technique where using an amniotic membrane also, this patient, again, you just have to have, it's kind of like a tuck-in technique where you freshen the edges. I place the Tenons first, take the suture, and following that I then put the amniotic membrane, and you can either glue it or take sutures as per your. This is, you can see again the mattress suture I've taken for both of them together, but I think glue also could possibly use. So technique is very easy, it's nothing, it's not really very fancy or difficult. Now these are cases which Dr. Somshila has kindly shared. This is what I was talking about, in infective, though in most of the literature is describing that it's not to be done in infective, but in this case, they have used it successfully. This is a patient where was diagnosed as HSV keratitis and was on antivirals, and later they found that it was Mycobacterium species on scraping, and this is what the microbiome report of the patient. As you can see, there was Mycobacterium found, and patient was started on amikacin 2.5 eye drops, and after the infection being controlled, there was thinning which was seen at around 6 weeks, and then the glue BCL was applied at this visit. And then I think again applied 1 week later, which probably there was sloughing of the glue, and that's when the Tenons patch was applied, and this was the Tenons patch 3 months and 1 year post TPG, where the patient then underwent cataract surgery 1 year later, had a good final visual acuity. So so I'm sorry about that slide. So the points from this case was that it works well in post-infectious cases also, as long as the infection is well under control. So we all know that there is a inflammation phase which comes in even in an active infection, where there's more lysis happening and not so much infection, especially if you've got the patient under good antibacterial cover. So I guess that's the phase when you can use it, not when there's active infection. Now Tenons in this patient obviously did not integrate well and did cause a like a formed a dense white scar in the center. So probably maybe the take home would be that it's not very good for central perfs, so might as well then use a patch graft. But the other good thing is that they could do a phaco in this case, so that means the tectonic stability is as good as a corneal graft. Now this is another patient with shared by Dr. Somshila, where 35-year-old male with a trauma a month ago, again microbial keratitis with gram-positive cocaine smears, and TA-BCL with intraocular antibiotic and intense intraocular antibiotic injections was done. And I think all of us have these kind of patients where you keep repeating the glue and the patient keeps perforating and the BCL keeps popping out, and then they done a Tenons patch graft and tarsorrhaphy. And ultimately the patient has done well. This is at post-op 3 weeks, and this is at post-op 2 months. So the take home from this case was that it was combined with cyanoacrylate glue application as an additional layer, and obviously it helped in not having to do a corneal graft, especially a therapeutic graft. It could be avoided, and we can then probably do an optical graft at a later stage as needed. So complications, pretty much I think the most the others seem innocuous. The most I guess the failure of surgery would be a complication where you're having a melt, especially in the immune cases where your graft is also melting away. That would be considered as a complication. Hence, I'd like to summarize that it is a very simple and effective procedure. We don't need any tissue from the eye bank, and obviously it's low cost, and there's decreased risk of vascularization. And also I feel that especially with the fibroblast being different from corneal, from corneal fibroblasts, less inflammation, there is a long-term potential, especially if you don't have it's not a very central perforation. And then if you've got the scarring, if it's central, you have to do an optical keratoplasty, but otherwise you can get away with managing with rigid contact lenses. Thank you so much for your time.